Hi everyone, welcome back to UWorld's NCLEX review. My name is Samantha. I'm a nurse here at UWorld, and we are so excited to have you all back today. So let's go ahead and get some things started. Welcome back from the holiday weekend. I know a lot of you guys are probably in crunch time for taking the NCLEX. January and February are some really big testing months, so we're trying to hit some big topics for you all today, and those are going to be based around pediatric conditions. The ones we'll cover today are RSV, strep throat, and head lice. So with that being said, let's get a couple housekeeping things out of the way before we jump in. So we do take into account the things that you all want to see. So keep letting us know in the chat the topics, the body systems, the diseases and disorders that you want to see us proliferate more on. There will be questions throughout today's videos, kind of knowledge checks along the way, as well as our NCLEX style questions at the end. So stay tuned, make sure you don't miss out on those. If you haven't already, please follow us at UWorld Nursing on whatever your preferred social media channel is so you don't miss any of these live lectures or the live question drills that we do. We're now going live 5 days a week, 7 times a week, so lots of great and most importantly free content for you all. But if you don't subscribe, you're going to miss out on some of it. So go ahead and do that. We just hit 100K followers on TikTok, so thank you to everyone who made that possible. And if you haven't subscribed yet, go ahead and do that now to be a part of a great community. This live will be on demand on our YouTube channel after we're done. So if you have to head out early, maybe you're kind of dropping in and out, no worries. You can always reference it there, go back and use it for your future studies. As always, we love to interact with you guys. So let us know in the chat any comments, questions, and of course answers to today's questions that you may have. We have the wonderful nurse Jasmine moderating for us. So let her know any questions that you have or anything you want a little bit of clarification on. Let's go ahead and get started by seeing where everyone is joining us from. I see we already have one viewer, Sama from Egypt. Welcome. We're so happy to have you. Let us know where you're from, whether it's Eastern Hemisphere, Western Hemisphere. It's always so cool to see just how far UWorld reaches. I see a Shreveport, I see Kenya, Canada, Florida. So exciting. So thank you all for joining us. Again, hopping to our agenda, we're covering 3 topics today: RSV, strep throat, and head lice, with those questions scattered throughout. So let's go ahead and get started. Let's start out with that bronchiolitis or RSV, and we're going to pull up a great table for you guys. RSV is short for respiratory syncytial virus. It's very, very common. It's a common viral infection that affects so many kids during cold and flu season, which we are right in the middle of. So if you go into a pediatric ER, a children's hospital in the winter months, so much of what you see is going to be RSV related. So what happens with RSV? First of all, it's a very communicable disease, meaning it's a very catchy virus, so to speak. It's spread by respiratory droplets by direct contact. So like child to child, or through indirect contact, like through child to toy, and then another child picks that toy up, maybe they touch their mouth afterwards, and then they contract the virus. So think sneezing and coughing when you hear droplets. To further go into the path, though, in our lungs we have small tubes called bronchioles where air passes. So bronchioles are going to be the smallest branches in our airway. In RSV, these bronchioles will get inflamed and mucus secretions increase. Now that inflammation paired with the mucus secretions are our 2 hallmarks of RSV here. It's going to make it harder for air to pass altogether, which essentially makes it harder to breathe. So big picture RSV, it's all in the name. It's respiratory, so big picture implication, big picture complication we're worried about is going to be respiratory distress. It's viral, so we know our treatment will most likely be supportive. And before we get into risk factors, a quick note is that RSV is diagnosed using a nasopharyngeal swab. This is the same as that original COVID test, that one that went real high up your nose, very uncomfortable, very unpleasant, especially for the kiddos. So we're definitely going to need to use some of our therapeutic communication techniques and age-appropriate communication. So what are our risk factors? RSV is a virus that affects our youngest populations, but that's not it. It can also affect our oldest generation. So infants 6 months and younger and elderly clients are at the highest risk for contracting RSV each year. They are also at the highest risk from developing complications from it. So it's also going to affect anyone that's immune compromised. So think about the clients who are undergoing chemotherapy, any client on an immunosuppressant medication, which is something maybe after a transplant, clients with any underlying pulmonary condition like asthma or cystic fibrosis, big risk factors there. Here, those lungs are already compromised. So when we introduce worsening inflammation to the airway, it's going to lead to a big problem for these clients. Now, kids that are exposed to secondhand smoke are also at a risk for complications from RSV. When children are around smoke, the inhalation of that smoke is going to cause inflammation in the lungs. Similar to what we said about our clients with existing lung conditions, when RSV enters the body and causes worsening inflammation to the lungs, complications are more likely to present themselves. So let's move along to those clinical features. So these will vary by severity. The onset of RSV will really vary, but typically we see it peak around day 5, with day 3 to 5 usually being the worst. So symptoms can be as mild as like runny nose, cough, sneezing, fever, sore throat, those really typical kind of cold and flu things. But over time, these symptoms can worsen, and they can actually get to a point where they threaten the A and the B of our ABCs, the airway and breathing. So we can differentiate RSV from a common cold because we typically see our symptoms from a cold only in our head, that stuffiness, that pressure. But with RSV, the symptoms are really going to present themselves mostly within our lungs. So before I pull up this next image for you all, please tell me, what do you think respiratory distress looks like in a pediatric client? And now we study this separately from our adults because our pediatric clients have a tendency to present differently than adult clients, especially when it comes to respiratory problems, because they have a weaker respiratory and immune system. They're still developing, they're still growing. So what does labored breathing, respiratory distress look like in a pediatric client? Drop your answer in the chat. And I see some great answers already. Nasal flaring, fatigue, retractions, mouth breathing, grunting, great job. Use of accessory muscles, you guys absolutely nailed it. So let's talk about what RSV is going to look like upon a respiratory assessment. It's going to look like this image of labored breathing and this sick little kiddo that we're going to bring up for you all. But we're going to start to see signs of respiratory distress and hypoxia. We're going to start out with that respiratory distress. So in a pediatric client, this will look like adventitious lung sounds, those wheezes, and crackles, I combine those, that we never want to auscultate. So wheezes happen when the air has a narrowed path to travel, almost like a whistle, and crackles happen from that built-up fluid. It sounds almost like bubbles popping. It always reminds me of Rice Krispie cereal. So these sounds are due to inflammation in the airway, which is going to cause the wheezing, and increased secretions, which is going to cause that fluid and lead to those crackles. Clients will also start to show use of the accessory muscles. The lungs just can't, take on this huge workload by themselves. They're going to pull in some accessory muscles and engage the muscles that typically aren't used for breathing, but we need that extra help to move air through the lungs. So we're going to pull in those accessory muscles. And sometimes it even looks like in a pediatric client, it's like a full body effort in order to get a breath. You may hear sounds like grunting, especially in our youngest infant clients. And we also are going to notice retractions, especially when you look around the ribs and the higher up neck. So there's a couple different places that we can look for retractions. The first one are going to be intercostal retractions, which will be between our ribs. We'll see ones below our ribs, kind of where it meets the abdomen. Those are called subcostal retractions. And another really common one are our suprasternal retractions, which hit right up here on the neck. We'll also see nasal flaring, tachypnea, which is just an increased respiratory rate, and of course hypoxia when we take vital signs, which would just be an O2 set under 90. So last part are nursing interventions. What are we going to do to help these sick kids? So we're mostly going to focus on interventions for the moderate to severe clients because those are the clients that are going to be hospitalized. But first things first, we have to prevent the spread of RSV, so we need our droplet contact precautions. So quick little break here. What do we do for our droplet contact precautions? Drop it in the chat. How do we need to suit up? How do we protect ourselves and prevent the spread of RSV? It's a tough question. I think precautions questions and infection precautions are always tricky. I used to always get them mixed up. Alrighty, I see a surgical mask. Way to go. And droplet contact kind of takes droplet just a little one step further because, again, we can have that indirect spread when a child who's sick touches a toy, puts it down, another child picks it up and plays with it, and then they end up contracting RSV. All right, I see mask, gown, gloves. Okay, lots of great answers. So contact precautions for droplet infections are going to include our gown, our gloves, and a mask. We don't need an N95. RSV is droplet, so think like a sneeze versus airborne, which is just spread through breathing or through talking. So now that we're dressed and ready to care for this client, we want to focus on supportive care. This is going to include administering IV fluids to keep the client hydrated. Also, the more hydrated we are, the more we can thin those secretions, making them thinner and easier to expectorate or cough up. We need to closely monitor the oxygen, those O2 sats. We want to keep this client over 90% if we can, and also consider adding like a humidified oxygen to help further break up that secretions, relax and open the airway. These clients are also likely to have a super high fever, which is so dangerous for these pediatric clients. So we want to give an age-appropriate antipyretic like an acetaminophen or a Tylenol. So we don't give aspirin to pediatric clients with viral illnesses. And I'll say that one more time. We don't give aspirin to pediatric clients with viral illnesses. Does anyone know why that is? What are we worried about here? What is the reasoning for not giving aspirin to a pediatric client with a viral illness? I'll give you a few seconds. I know you're going to get it. And someone on TikTok, as well as Amber on TikTok, got it, Ray's syndrome. We are worried about that. So this is associated with taking aspirin while sick with a viral illness. It's common in pediatric clients. So we avoid that aspirin and instead we give a Tylenol or an acetaminophen, which is, we're worried about Ray's syndrome in case anyone did not hear that one. So that's our big worry. That's the little safety check there. Other things we can do as part of our nursing interventions, we want to ensure a position that promotes airway clearance. So for these pediatric clients, think about 30 to 40 degrees of elevation. We also want the neck slightly extended, really open up that airway. This is especially important for babies because we don't want them all smushed together. You want their neck extended so the airway is nice and open, everything is midline. We also want to do frequent suctioning. So chances are these pediatric clients will not like this. So this would be a good time to use some age-appropriate communication. For our smallest infant clients, swaddling them, this is a great time to do that so their hands don't get in the way. For toddler clients, we might want to be able to explain to them first what's happening and let them look at a separate non-sterile piece of equipment that we're going to use the same type but not that same piece, just so they can see what happens. These clients need the suctioning because they're a lot of times not able to clear a lot of these secretions on their own. So we also want to monitor those eyes and nose, make sure the client is not getting dehydrated. Again, with that fever, they're probably not going to want to eat as much. They're not going to have much appetite. They may not be drinking as much. So monitoring eyes and nose is a really great little marker on where we stand with our hydration status. For our youngest infant clients, this can look like monitoring diapers, weighing and counting diapers. We also want to monitor activity level, looking for signs of decompensation, especially in a client with labored breathing and respiratory distress that puts so much stress and demand on the body. Now, pediatric clients are pretty resilient, but when enough is enough, some of these viral infections, you'll know when something isn't right. They may suddenly become listless, have no activity. Those are signs of decompensation that we really, really would be worried about. And lastly, always monitor for secondary infections. Whenever there's stagnant mucus like that, it's a breeding ground for other bacteria, other viruses. So keeping an eye out for pneumonia. Things like acute otitis media can also be an opportunistic infection. That would just be an ear infection. But again, that thick mucus is just absolutely loved by bacteria and viruses and fungi all alike. So moving on, we're now wrapped for our RSV part of the lecture. Let's jump to streptococcal pharyngitis, or strep throat for short. So strep throat is a bacterial infection. So switching gears, RSV was viral, strep throat is bacterial. Another super common pediatric condition. It's caused by the Streptococcus pyogenes, which is group A, beta hemolytic streptococcus. It's diagnosed by a throat culture or a rapid strep antigen detection test. We always want to perform the diagnostic test for strep throat, but it has several distinct symptoms. It's going to key you in to the need to actually perform that test, which is what is going to lead us to our next part, or the clinical features. So what does strep throat look like? Our clinical features include things like a really abrupt onset of a sore throat. Maybe all of a sudden you wake up in the middle of the night, you have one, you get up in the morning, and all of a sudden your throat is just so sore and raw. It may look like redness in the back of the throat. Clients can see swollen tonsils with exudate even sometimes. Palate petechiae, pinpoint red spots on the palate can appear. Clients, of course, will have fever. We can see anterior cervical lymphadenopathy. And pro tip for kids here, sometimes they present atypically, so against the norm. They'll have symptoms like an upset stomach from that bacteria making its way down to the stomach and causing some GI upset. So if it presents with more GI stomach symptoms, it can still be strep throat, but sometimes these pediatric clients will present atypically. Now we're going to take a detour from clinical features and talk about some complications of untreated strep throat that are unique to strep throat, but some of these are common in anything that's caused by that strep bacteria. So first off is something called a peritonsillar abscess, and we're going to pull up a picture that's not too pleasant, so if you're squeamish, please look away, but it just means an abscess on the tonsil essentially. These can be an emergency because they obstruct the airway, so they're going to present with fever and chills, really terrible pain that's bad enough for them to really not want to eat or swallow any liquids. A lot of times they even have a muffled voice because the swelling of the tonsil can cause that deviation of the uvula. It can really affect our speech. The next complication is something called rheumatic fever. We have a table that defines all of these things, but it can take about 2 to 3 weeks to surface after that initial strep infection. Again, all of this is from untreated strep throat. But what happens is that antibodies against the strep bacteria develop and attack the healthy tissues in our heart, our joints, and our kidneys. So what we worry about most is pericarditis, which is inflammation around the heart. We can also see joint pain and chorea, which is involuntary muscle movements. Now, our next complication from untreated strep throat is quite a mouthful. It's acute post-streptococcal glomerulonephritis. So again, untreated strep throat, we have that invasion of the strep bacteria down into the kidneys. Most times it's manifest as peripheral edema from impaired kidney function. It's kind of the same idea as when we have an adult with an acute kidney injury or an AKI. Our real hallmarks of this will be hypertension and Coca-Cola colored urine. So really, really dark urine. That sounds distressing to hear. The color urine here is essentially a color variation of hematuria, which is blood in the urine. Instead of that frank red blood with hematuria, it's going to be that dark brown. So again, distressing to see, but this is a sign of, we can just call it APG. And last but not least is scarlet fever. So this is going to present as a sandpaper-like rash. We can even see a strawberry tongue, have that beefy red with the papules that make it look like a strawberry. That's where that gets its name. But again, all from untreated strep throat. When I think about scarlet fever, it was really dangerous in the olden times. If you ever were a Little House on the Prairie fan, Mary gets this. But all right, last part of strep throat is our nursing intervention. So again, it's a bacterial infection. No surprise here, our treatment for a bacterial infection are our antibiotics. So in this case, go ahead and drop in the chat what antibiotics you think we're going to use for strep throat. I'll just give you a few seconds. And I'll go ahead and just walk through this and reveal the answer. But for clients without a penicillin allergy, we are most likely going to give a penicillin. For those with a penicillin allergy, we'll probably give something like a cephalexin, but we also need to offer supportive medications. So antipyretics, really important here. We want to bring those fevers down. We want to give analgesics to help with the pain, especially that sore throat. We need to teach the client or their caregivers about consuming soft foods, cool liquids. Other comfort measures can include a humidifier in the client's room. Again, the humidified air is gentler on the client's airway, and also that humidity helps to break up some of those secretions. Clients can gargle with warm water. It's going to help reduce pain, and the solution of salt water also helps with inflammation. and we're going to do some really important teaching to prevent strep from reinfecting the client. So first we need to teach the caregiver the client is considered contagious until 24 hours after starting antibiotics. So that means typically keeping them home from school until they've been fever-free for about 24 hours. We also want to tell the caregiver to discard the toothbrush 24 to 48 hours after starting the antibiotic so they don't use that infected toothbrush and reinfect themselves with strep. That is our last point for strep, and now we're going to move into pediculosis, capitis, because what would a pediatric lecture be without a talk about head lice? So head lice, fancy name is pediculosis capitis, is a rite of passage for nurses. I also feel like you're more likely to get this as a new nurse for whatever reason, but lice is a very contagious parasitic infection. So now we've kind of rounded it all out. We had a viral infection with RSV, a bacterial infection with strep, and now we're on to a parasitic infection with lice. So it's spread through contact, either direct, meaning kid to kid, or it can be indirect. So maybe a pediatric client uses a hairbrush, they leave it on a table, another kid picks it up, oh, that kid before us was infected, now when they use it, they contract the parasitic infection. So let's walk through the lifespan of what happens with lice. So first, a female lice lays an egg called a nit on the hair shaft close to the scalp. Over the course of 2 weeks, those nits will develop into full-grown adult lice. Then those adult lice continue to lay more eggs, and the process continues until it gets way out of hand or until the infection has been treated. Without treatment, lice multiply very, very quickly. That's a 2-week lifespan right there. Lice is most commonly seen in school-aged children who are in childcare facilities, really any place where kids are in really close contact with one another. So clinical features are pretty straightforward for lice. Simply, it's itching. Kids are going to have really severe itching. We call that pruritus. Scratching can also lead to excoriation on the scalp, which can be a really big concern for subsequent skin infections. Nits can sometimes be seen behind the ear, maybe at the nape of the neck. What they're going to look like are really light colored specks in the hair. So pretty much itchy scalp, visible lice are our biggest manifestations of pediculosis capitis. So last but not least, our nursing interventions. Now these are going to be pretty heavy for lice. There's a lot of things we need to do here. So in a healthcare facility, you always want to protect yourself first. So we want to cover up before helping any client. This will typically be at a facility-specific minimum. You're going to want to put on a gown and gloves. In all reality, you really want to cover your hair, especially if you have long hair. So tie it up, put a surgical cap on, protect yourself there. The next thing we do are to instruct the client or assist the client to apply a pediculicide shampoo. A really common concentrate here is that 1% permethrin to the scalp. We need to tell the client or the caregiver, depending on their age, to leave it on for a full 10 minutes to let us get the full therapeutic effect, then wash the hair in the sink so they decrease the skin exposure when washing everything out. And we also want to wash the hair in warm water, not hot water, to decrease vasodilation so we don't see a systemic absorption of this medication. Now, after shampooing, the client should run through their hair with an extra fine tooth comb to help remove those nits. And most importantly, this process needs to be completed in its entirety in another 7 to 10 days to make sure we're treating any newly hatched lice. The caregiver also needs to soak any pre-used infected hairbrushes in hot water for 10 minutes. Lice travels so fast in households, so we also have to make sure that the other kids, the other members of the household are being checked for lice too. In terms of the house itself, vacuum all the carpets, mattresses, and upholstered furniture, and wash any bedding or anything removable in hot water and dry it on the hottest setting. Now for any non-washable items, they need to be put in a bag that seals for 2 weeks to suffocate those lice. And we also want to make sure the client is keeping their nails trimmed. We don't want any excoriation from the scratching. That's a big risk for secondary infection. And lastly, a really big part of lice is going to be therapeutic communication. This can be isolating. This can be embarrassing. We never want the client or their caregiver to feel that way. So keep an eye out for any questions that kind of cue to them being embarrassed about it. And we want to make sure we treat this with compassion. Alrighty, so first question, we have a special 3 questions today. So bonus question from our norm. But in this case, let's go ahead and go to question number 1, which is our RSV question. So the nurse is caring for an infant with respiratory syncytial virus, or RSV. Which of the following findings would the nurse expect to observe? And it's a select all that apply option. So our options are fever, tachypnea, poor feeding, sunken fontanelles, or tearless crying. Drop your answers in the chat. Let us know what you all are thinking. And if you haven't visited yet, you can go to uworldnursing.com. It has our full calendar of events, links to our social media, links to buy the product. It's like our home base for all of our nursing social events. Someone on Instagram, Soph, asked, is there a way to replay the whole session? There sure is. It's on YouTube. Go to our UWorld Nursing YouTube channel. You can click the live tab and it has all of the lives that we do. So it usually gets, I think, immediately uploaded. If not, it may take a few minutes, but it should be there by the end of the day. If you joined us late, if you have to duck out early, that's a great way to still be able to access all of the information. Alrighty. I see almost all correct answers. Way to go, you guys. But our correct answers here were 1, 2, and 3. So why was this? Fever, true. We talked about this. We talked about the need for an age-appropriate antipyretic, which again just means not aspirin. We're going to give an acetaminophen or a Tylenol. Tachypnea, we know we're going to see an increased rate of breathing. This one is true. And poor feeding. If a child can't breathe properly, they're not getting good oxygen in, they're not going to want to eat or put anything else in their mouth. So 1, 2, and 3 are true. 4 and 5 were incorrect. So 4 could be kind of tricky. Sunken fontanelles is typically a sign of dehydration. Now, a lot of you may have chosen this because we talked about it, when in reality, dehydration can result from RSV, but it's a complication rather than a direct result. So again, always important to make sure we know what the question is asking. It's asking for these manifestations, expect to observe. It's not asking for complications. And lastly, tearless crying would also be incorrect in this case. So moving on to question number 2. Someone asked, what causes sunken fontanelles? Dehydration. Question number 2, the nurse in the clinic has taught a client with newly diagnosed streptococcal pharyngitis, which the following statements by the client would indicate a correct understanding of the teaching. It's another select all that apply. We are challenging you all today. But in this case, our options are, I plan to place a humidifier in my bedroom. I should contact the clinic if my urine color changes. I will receive a prescription for an antiviral medication. Drinking cool citrus juices will be soothing to my throat. Or gargling with a warm saltwater mixture may alleviate my pain. Again, select all that apply, so multiple correct answers here. I also want to draw everyone's attention to our retaker offer. So we know there's people that unfortunately were not successful with their very first NCLEX attempt, and there is no shame in that. We are offering a special offer. You can go to uworldnursing.com to get this, but if you are someone that didn't pass the first time and you do need to retake, simply upload your CPR or candidate performance reports, and we will give you a special offer for a discount on a 30-day UWorld subscription. So if we have any second, third time test takers, there is no shame in that. We are glad you came to UWorld for help this time. Make sure you take advantage of that special offer. Currently, I don't know how long we will be running it for, but you always want to make sure you strike while the iron's hot. So. All right, lots of answers coming in. And it seems like y'all did a little bit better on the prior one, but no worries. We will go through this all in full. Our correct options here were 1, 2, and 5. So in this case, the humidifier, this is great. It helps to soothe the throat. That extra humidity in the air that we breathe in can break up those secretions, making them easier to expectorate. Urine color changes. That's something that's really concerning for that acute post-streptococcal glomerulonephritis. We definitely need to make sure we're keeping an eye out for that dark cola-colored urine. And lastly, 5, gargling with warm saltwater mixture may alleviate my pain. This helps to reduce the pain, soothe the throat, and really work to relieve some of that inflammation. 3 and 4 were incorrect. I hope that no one chose option number 3 because strep is bacterial. We're not going to take an antiviral. And option 4, drinking cool citrus juices will be soothing to my throat. Citrus is acidic. When you have a raw sore throat and you drink something acidic, it's going to burn. It's not going to be soothing. So that's going to have the opposite effect. So again, 1, 2, and 5 were our correct options. Way to go, you guys. All right, last question. The nurse is teaching the parents of school-age children about the treatment of pediculosis, capitis, or head lice. Which of the following information should the nurse include? Select all that apply. So wash your child's bed linens in cold water. Keep your child's fingernails trimmed short. Remove nits from your child's head using a fine-tooth comb. Treat all of your household pets with a pediculicide, or seal non-washable items in a plastic bag for 10 to 14 days. Drop your answers in the chat. Let me know what you all are thinking. Also, let us know, when are you guys testing? Who is about to take their NCLEX? Who just graduated in December? Who is planning on being a May or a spring graduate? Let us know. Alrighty, next week, lots of next weeks. Good luck, you guys. You're gonna do great. Someone takes it tomorrow. Good luck, Kina. Alrighty, so lots of answers coming in, almost all correct answers. We are finishing on a high note. Way to go. 2, 3, and 5 were our correct options. So we know we want to keep those fingernails trimmed short. We don't want any scratching that breaks the skin because that's an opportunity for a secondary infection. So definitely keeping those fingernails nice and short, filed down, trimmed short with a nail clipper, whatever works. Option 3, we do want to remove the nits using that fine tooth comb. It helps get the nits at the scalp to remove them and prevent worsening infection. And lastly, 5, anything that we're not able to shove into a washing machine and a dryer, we are going to put in a sealable plastic bag for 10 to 14 days to suffocate any of those remaining lice. Our incorrect options were 1 and 4. We need hot water, not cold water, when we wash these linens. And 4, pets actually cannot get head lice. It requires a human host, interesting enough. Just like humans can get bitten by fleas from pets, but fleas cannot live on a human. Interesting. Some things just truly don't go between dogs and people. For instance, my dog got pink eye over the weekend, and apparently that's not communicable between humans and dogs. So you learn something new every day. But thank you guys so much for joining. I so appreciate it. Here is a little look into our Q bank. For anyone that's already purchased our product, here's how you can select and what you can select to target exactly what we worked on today, so you can get more questions based on pediatric illnesses. And for anyone who has not purchased yet, we can make sure you get a look into what our product looks like. This is just one of so many ways you can filter our questions to practice exactly what you are trying to improve. So if you haven't purchased UWorld, I cannot recommend it enough. We definitely want to make sure you're staying on top of your study journey, and UWorld is simply the best way to do that. So in closing, thank you so much for staying tuned. I hope that this was helpful. Today's lecture was a long one, but pediatric clients often present differently from their adult counterparts. So it's so important to study how the pediatric clients can manifest differently, so we can catch these things in our smallest clients. But you all did such a great job. Way to go. We're going to be back tomorrow at 11 a.m. and 7 p.m. and we can't wait. So see you all soon. Bye-bye.